Welcome to the deep dive. Today, we're plunging into a world where incredible strength meets, well, hidden vulnerabilities. Horses are truly magnificent, resilient creatures, aren't they?
Absolutely.
But, like all living beings, they can face health challenges that aren't immediately obvious. I mean, think about it. How often do we really get a thorough, long look inside their mouths?
Not often enough, usually.
Exactly. Problems in there can go unnoticed for far too long, kind of lurking hidden in plain sight. That's why today we're taking a deep dive into equine oral tumors, a condition that, while maybe less common than some other health issues, presents some really unique diagnostic and treatment challenges.
Definitely unique challenges.
Our mission for you, our listener, is to give you the inside scoop on these tricky tumors. We'll explore everything from their varied types and those subtle, often missed signs, to the cutting-edge diagnostic and treatment approaches, all drawn directly from the expert sources you provided. Think of this as your shortcut to understanding a critical and often overlooked aspect of equine health, giving you those, aha moments.
Mm-hmm.
And here's why this deep dive really matters. For equine oral tumors, early detection is the single most critical factor for a better prognosis.
Absolutely key.
Knowing what to look for and why it's sometimes so hard to find could genuinely make all the difference. So let's really dig into this big challenge. Why are oral tumors so incredibly tricky to spot in horses? It seems to come down to this problem of them being hidden in plain sight.
That's exactly it. The oral cavity, by its very nature, it's dark, it's complex, and often pretty inaccessible.
Right.
So this frequently means that by the time a tumor is discovered, well, the disease is already quite advanced, just because it's been silently growing back there.
Hidden away.
Yeah. And the clinical signs typically only become obvious when the tumors have grown large enough to physically interfere with basic functions like eating or breathing, or, when they start causing significant local irritation.
Horses are pretty stoic, aren't they?
Incredibly stoic. The horse often adapts and masks discomfort for a surprising amount of time until it's just too severe to ignore anymore.
Okay. So, if the horse is masking discomfort, what are those first whispers of trouble? What should horse owners, caretakers, be watching for? What are those crucial alerts?
Well, it often starts subtly. One of the primary things to watch for are changes in eating, difficulties eating.
Oh.
This could be quitting, where a horse drops partially chewed food.
Ah, right. I've seen that.
Or you might notice them eating much slower than usual, maybe showing reluctance to eat hay, or even outright refusing hard feed. Any significant change in their normal eating routine as well as a red flag.
And beyond just how they're eating, I imagine changes in what's coming out of their mouth could be a sign too.
Absolutely. You might see oral discharges like excessive salivation. Tyolism is the technical term.
Sorry. Pardon.
Halitosis, just persistent bad breath, which can indicate infection or tissue death, necrosis within the tumor. Visible oral bleeding, even if it's just a trickle, that's another serious indicator.
And sometimes the problem literally shows itself on the outside, right? Like a noticeable lump.
Precisely. Facial swelling or a visible deformity, like a lump on the jaw, cheek, or lip, that can definitely be a sign of a growing mass underneath. And if a tumor invades the nasal cavity or sinuses, you might see respiratory or nasal issues.
Like discharge.
Yeah, specifically a purulent, like pus-filled or bloody nasal discharge.
Okay. What about more subtle behavioral shifts, maybe related to the tongue or how they react to, say, the bit?
Good point. Don't overlook changes in tongue behavior. This could be the tongue protruding abnormally or just unusual movements during eating. A reluctance to accept a bit, that's a classic one. Or sensitivity when you palpate the head and jaw. Those can also be warning signs of discomfort deep inside. And then if eating becomes severely compromised, you'll start seeing systemic effects like loss of appetite, weight loss, maybe recurrent fever, or just general depression.
It all connects.
It does. And finally, if the tumor invades the actual dental structures, you might see loose or displaced teeth.
Wow. It really sounds like a comprehensive checklist for vigilance. It underscores how much responsibility falls on owners and caretakers to notice these things.
It really does. Spotting any of those signs should prompt an immediate call to the vet.
Truly valuable information for anyone involved in equine care. Okay, so recognizing those subtle cues is the first critical step. But even then, knowing what you're up against, It can be surprisingly complex. It's not just one type of intruder, is it?
Not at all.
We're dealing with a whole rogues gallery of tumors, each with its own unique behavior and challenges. Let's unpack this surprising variety. Where should we start?
Well, we should probably start with squamous cell carcinoma, or SCC.
Mm-hmm.
This is, hands down, the most common oral malignancy we see in horses.
SCC, okay. And how does it typically present? What does it look like inside the mouth?
SCC can appear in a couple of distinct ways. It might be a proliferative, mass-like growth, sometimes described as cauliflower-like or just highly irregular in texture, or it could be a partially ulcerated, multi-lobed mass.
Yeah.
Alternatively, it can present as more of a flattened, open sore that's really destructive to the surrounding tissue, ulcerative and destructive.
And location-wise, does it
Yeah.
have preferences?
Not really. It can show up on pretty much any mucosal surface, the gums, tongue, palate, pharynx, even the tonsils and larynx.
Wow.
What's crucial to understand about SCCC is its behavior. It's locally invasive and highly destructive.
Meaning it spreads locally.
It grows into the tissues right around it.
Yeah.
Now, while it tends to metastasize or spread to distant sites, slower in horses compared to some other species, it can spread to regional lymph nodes, and, less commonly, to distant organs.
Are there specific risk factors?
Mm.
Or are certain horses more prone to SCC?
Yes, chronic inflammation, like the kind you get from severe periodontal disease, gum disease, basically, that's suspected to play a role.
Makes sense.
Also, infection with Equus-Caballus papillomavirus 2, ECPV2 for short, that specific horse virus, is a suspected risk factor in some cases, and it's typically seen in older horses. So given all that, the prognosis for SCC is generally, well, guarded to poor, especially if it's advanced or located in those really hard-to-access areas like the back of the throat.
Right, that makes treatment tough. Okay, next up, melanoma. And for this one, there's that strong gray horse connection, isn't there?
Absolutely.
It almost feels like a rite of passage for some older gray horses.
You're not wrong. Melanomas are highly common in gray horses, and yeah, it's almost expected as they age. They typically present as black, firm, nodular masses.
Little black bumps.
Exactly. Or they can form sort of tumorous plaques that infiltrate areas like the corners of the mouth, the lips, or the soft palate. Now, in gray horses, these are often benign and slow-growing.
Often benign. Okay, that's good news.
It is. However, they can become malignant, especially in non-gray horses, or sometimes in younger gray horses, or just if they start growing rapidly and becoming invasive.
So generally a good prognosis for controlling them in gray horses, but you still need to keep an eye on them, especially if they start changing.
Exactly that. Vigilance is still key. Prognosis is generally good for local control in grays, but always depends on location and invasiveness. Rapid growth or ulceration, that's a definite red flag.
Got it. Now, sarcoid.
Oh.
This one's fascinating because it's the most common skin tumor in horses, but it can unexpectedly pop up in the mouth.
It's a bit of a curveball, yeah.
What makes an oral sarcoid particularly problematic?
Well, their appearance is highly variable. They can be verrucous, which is wart-like,
Wart-like.
fibroblastic, which is more fibrous and fleshy, nodular, a distinct lump, occult, kind of hidden under the surface, mixed, a combination, or even malevolent, which signifies a particularly aggressive form.
Wow, so many forms.
Yeah. And the challenge with oral sarcoids is their locally aggressive nature. While they don't spread to other organs, they don't metastasize, they are highly infiltrative.
Meaning they grow deep.
They grow deep into surrounding tissues, and that makes it incredibly difficult to get wide, clear surgical margins in the confined space of the mouth.
Ah, right. Not much room to maneuver in there. So even if you remove it, the chances of it coming back are high.
Precisely. The prognosis for complete resolution is guarded. There's a high recurrence rate, especially if that initial surgical excision isn't truly complete, doesn't get all the microscopic tendrils.
Tricky ones. Okay, let's talk about the ossifying fibroma, sometimes called juvenile mandibular ossifying fibroma. This is often known as the young horse jaw tumor, right?
Yeah.
Sounds quite specific.
It is quite specific. This is the most common bony tumor of the mouth we see, and it typically affects the rostral mandible, the front part of the lower jaw, in young horses, usually between, say, 2 months and 2 years of age.
Youngsters.
Yeah. It presents as a firm, usually non-painful, bony swelling of the jaw, often located just below the incisor teeth. It can become ulcerated if it gets bumped or traumatized. The most common presentation is a unilateral, one-sided bony growth on the front part of the lower jaw.
Despite its appearance, it's benign, which sounds like good news.
It is benign, yes, but it's locally expansile and destructive. It grows and can damage the surrounding bone, but it doesn't metastasize, doesn't spread elsewhere.
Okay.
So the good news is the prognosis for ossifying fibroma is generally good, provided you get complete surgical excision.
Surgery is key there.
Hmm.
All right, finally, we have odontogenic tumors, essentially dental tumors. These originate directly from dental tissues.
Exactly. They are born from the tissues that form teeth. These are less common, but important.
What types are we talking about?
They include types like ameloblastomas, ameloblastic fibromas, and odontomas, which can be compound or complex. Ameloblastomas, for instance, are benign but locally invasive. They often occur in the lower jaw and can really distort the mandible.
How do they look on X-ray?
On an X-ray, ameloblastomas typically appear radiolucent, meaning they look darker, like an empty space where X-rays pass through easily, suggesting bone destruction.
Okay, and the others?
Ameloblastic odontomas are also benign, but they're slowly expanding and locally invasive. On an X-ray, they tend to appear radiopaque, showing up as a brighter, denser area, often containing tooth-like structures.
Interesting difference. And they usually appear as firm swellings on the jaw, maybe with other dental issues.
Correct. Often firm swellings on the maxilla or mandible, sometimes with associated dental abnormalities or even discharge coming from around the teeth in that area.
And behavior-wise, still locally invasive.
Locally invasive and destructive, yes, but thankfully they are usually benign and don't metastasize.
Is there an age difference for these?
There often is. Ameloblastic odontomas tend to appear in young animals, from around 6 weeks up to a year old, whereas ameloblastomas typically occur in older horses.
Gotcha. And prognosis?
Generally good with complete surgical removal, though, again, the anatomical location can make surgery quite challenging, getting all of it out. Ameloblastic odontomas might have a slightly better prognosis because their growth is more by expansion rather than infiltration, which can make them a bit easier to remove cleanly. What's truly fascinating here is how the specific cellular origins of these tumors dictate their distinct behaviors. It influences everything from appearance to how they grow and invade.
It's complex biology.
It really is. And it's also worth noting, because these are relatively rare, there's historically been some inconsistency in how different veterinary pathologists classify them. The nomenclature isn't always uniform.
Okay. And just for completeness, while very rare, there are other malignant tumors that can pop up orally.
Yes, definitely. Things like fibrosarcoma, hemangiosarcoma, lymphosarcoma, which sometimes favors the hard palate, also rhabdomyoma, or the malignant version, rhabdomyosarcoma of the tongue muscle, myxomatous tumors, and even adenocarcinoma, which can sometimes arise from salivary glands in the mouth. It really is quite a spectrum we have to consider.
Wow, quite a lineup. Given how elusive these tumors can be and the variety, the real artistry seems to lie in how veterinarians manage to uncover them. It sounds like high-stakes detective work.
It absolutely is a detective job.
How do they begin to put the pieces together once an owner suspects something's wrong?
A thorough, systematic diagnostic approach is vital for an accurate diagnosis. You can't just, glance in the mouth and know what's going on.
No, I can imagine. So that starts with a really thorough oral examination, right? What are the key tools for that, especially for seeing beyond what's immediately visible?
Correct. It nearly always requires sedation. The horse needs to be relaxed, and the use of a full mouth speculum, that device to hold the mouth safely open, is essential.
Right, the speculum.
That allows you to properly visualize all parts of the oral cavity: the tongue, palate, gums, the cheek lining, the pharynx way in the back, and the dental arcades.
But that's just the start.
Just the start. You need a bright light source, obviously. And an oral endoscope is invaluable.
A camera.
Yeah, a small camera on a flexible tube. It helps examine those less accessible areas like the base of the tongue, the pharynx, maybe even inside the guttural pouches. And don't forget digital palpation, actually feeling the mass and surrounding tissues. That's essential to assess its consistency, how deeply it seems to have invaded, and if there's any pain associated with it.
So, visual and tactile. And for the definitive answer, after all that looking and feeling, it sounds like a biopsy is the absolute key.
It is the gold standard. A biopsy, whether you take just a piece, an incisional biopsy, or remove the whole thing if it's small, an excisional biopsy submitted for histopathological examination. That's the definitive method.
Tells you what kind of cells are there.
Exactly. It determines the tumor type and its malignancy, whether it's cancerous or not. And that information is critical for guiding treatment and establishing a realistic prognosis.
Is it always easy to get a biopsy?
Not always. It's relatively straightforward for a superficial SCC, maybe on the gums, but getting samples from deep pharyngeal or palatine tissues way back in the throat, that can be far more challenging. Often require specialized instruments, maybe even endoscopic guidance.
Right. Okay, once you're inside, imaging must be vital for seeing beyond the surface, especially if you suspect bone is involved. What's the go-to imaging?
Yeah, imaging is crucial. Radiography, or X-rays, is fundamental for evaluating bony involvement, like invasion of the mandible or maxilla, and for assessing the dental structures themselves.
Helps tell bone from soft tissue masses.
Exactly. And it can show characteristic signs. Like we discussed, ameloblastomas often look radiolucent dark on an X-ray. Ameloblastic adenomas tend to be radiopaque, bright. Osteogenic tumors often show smooth bony proliferation. SCC might show signs like teeth being displaced or loss of the bone around the teeth.
And for even more detail, that ultimate 3D map, there's computed tomography, CT scans.
CT is fantastic. It provides highly detailed 3D images. Excellent for determining the exact extent of the tumor, particularly with bone involvement, and it's invaluable for surgical planning. Lets the surgeon see exactly what they're up against.
What about MRI? Is that used much?
Magnetic resonance imaging, MRI, is actually even better for evaluating soft tissues, like the tongue and surrounding muscles. But it's less commonly used for oral tumors in horses, mainly due to cost and logistical challenges. Getting a horse into an MRI machine isn't simple.
Right, I can imagine.
Endoscopy, though, both oral and pharyngeal, sometimes even nasoendoscopy going through the nose, gives that direct visual assessment of the tumor's size, location, and its relationship to adjacent structures. Helps assess palatine and nasal involvement, too. It all helps build that complete picture of the enemy.
And of course, you'd also want to check the lymph nodes, see if the cancer has started to spread.
Absolutely crucial step. Palpation of regional lymph nodes, those under the jaw, the submandibular nodes, and the deeper ones in the throat, the retropharyngeal nodes, is important to check for enlargement.
And if they are enlarged,
If they are enlarged, a fine needle aspirate, FNA, or even a biopsy of the node can help determine if metastasis has occurred. But it's important to remember, reactive lymphadenopathy is also common.
meaning they swell up just from inflammation.
Exactly. Nodes can enlarge due to inflammation or infection nearby, not necessarily because cancer has spread there, so you have to interpret those findings carefully.
Okay. And finally, when looking at these masses, you'd need to consider other possibilities before landing on a tumor diagnosis, wouldn't you? What else might mimic an oral tumor?
Yes, differential diagnosis is key. Veterinarians always consider other conditions that might look similar, swellings due to underlying dental disease, particularly a periapical abscess, an infection at the root of a tooth. That's a common one.
Tooth abscesses can cause big swellings.
They certainly can, or even just the presence of foreign bodies lodged in the mouth or throat, a piece of wood, a wire, that could cause similar signs like difficulty swallowing, dysphagia, or that persistent bad breath, halitosis. It's all about ruling things out systematically to arrive at the right diagnosis.
Makes sense. So once the diagnosis is confirmed, the real strategic planning begins. What are the treatment options, and how does a vet decide the best course of action? The complexity here must be immense.
It is indeed immense. Treatment strategies have to be highly individualized. They depend on so many factors: the specific tumor type, its size, location, how deeply it's invaded,
And the horse itself.
and the horse's age, its intended use, plus, realistically, the owner's financial capabilities. A multimodal approach, combining different therapies, is often the most effective way to tackle these challenging cases.
For many tumors, I imagine surgical excision, just cutting it out, is still the primary goal if possible.
It's the ideal approach, yes. Complete surgical removal with wide, clean margins, meaning taking out a border of healthy tissue all around the tumor. That's the aim. Especially for benign tumors like ossifying fibromas or odontomas, and for early-stage malignant tumors.
But the oral cavity, it has to make that incredibly difficult. Such a tight space, so many critical structures.
It absolutely does. Achieving those wide margins is often extremely challenging. You've got vital structures like nerves, major blood vessels, salivary ducts, all packed in there, and very limited working space.
What techniques are used? Scalpel, laser.
Both. Techniques can vary from traditional scalpel excision to using something like a CO2 laser. Lasers offer some distinct advantages. They often reduce bleeding because they cauterize as they cut, they create sterile incisions, and potentially they might minimize tumor recurrence due to less tissue manipulation.
And for really big tumors.
Yeah.
Or ones you can't fully remove.
Right. For it is a very direct approach. Intralesional injections, often with chemotherapy drugs like cisplatin or carboplatin, these can be delivered as a liquid solution or sometimes embedded in tiny biodegradable beads that release the drug slowly right into the tumor site.
And that's effective.
It can be highly effective for local control, particularly for SCC and for sarcoids. For some SCCs, another drug, 5-fluorouracil or 5-FU, can also be used topically, applied right onto the surface, or injected intralesionally, targeting the cells directly.
Okay. What about radiation therapy? Is that common for horses?
It's used. Brachytherapy is one method. That's where tiny radioactive sources, like iridium-192 wires or seeds, are implanted directly into the tumor.
Right inside it.
Exactly. This delivers a high dose of radiation directly to the tumor while minimizing exposure to surrounding healthy tissue. It can be very effective for local control of various tumors, especially SCC and sarcoids, but it does require specialized facilities and expertise.
What about external radiation?
External beam radiation, like what's used commonly in human oncology, is also an option, but it's less commonly available for horses, mainly due to their size, the specialized equipment needed, and the logistical challenges of repeated treatments under anesthesia.
Makes sense. And freezing the tumor, cryotherapy, is that used for specific cases?
Yes, cryotherapy or freezing is usually indicated for smaller, superficial, and well-demarcated lesions. Things like papillomas, small sarcoids, or maybe some melanomas. Liquid nitrogen is applied to freeze and destroy the tumor cells. It's a targeted strike, but usually for less invasive things.
Gotcha. Then there's immunotherapy, harnessing the body's own defenses. That sounds promising.
It does hold promise. There's the melanoma vaccine, Oncepta, which is used in gray horses with melanomas. Now, it was primarily developed for skin melanomas,
Right.
but it may have a role in oral melanomas too, though its efficacy can vary quite a bit depending on the individual horse and the specific tumor characteristics.
Any other immunotherapy?
Bacillus calmette-guerin, or BCG, immunotherapy is also occasionally used for sarcoids. It's injected directly into the tumor to stimulate a strong local immune response against it.
Interesting. Are there any systemic therapies? Things like oral medications or traditional IV chemo that help? Or is that less common for these oral tumors?
Systemic therapies are generally more adjunctive, meaning they assist other treatments, or palliative for comfort when dealing with oral tumors. NSAIDs, the non-steroidal anti-inflammatories like piroxicam or meloxicam.
Like bute or banamine, but specific ones.
Similar class, yeah. Piroxicam and meloxicam have shown some direct anti-tumor activity, especially for SCC, possibly by inhibiting an enzyme called COX2, which is involved in inflammation and tumor growth. Plus, they help with pain and inflammation control.
Any others?
There's cimetidine, which is actually an antacid drug, but it has shown some anecdotal success in managing certain melanoma cases. Why it works isn't fully clear, possibly immune modulation.
Huh. Weird.
Yeah. But systemic chemotherapy, like IV chemo used in dogs or humans, is generally not very practical or well tolerated in horses for most oral tumors due to potential side effects and cost. It might be considered for metastatic disease in very specific situations or protocols, but it's not a mainstay for localized oral tumors.
So for advanced or inoperable cases, the focus shifts heavily to quality of life then.
Exactly. For advanced, inoperable, or metastatic tumors, the treatment strategy often pivots to palliative care. The focus becomes managing pain, maintaining the horse's quality of life as best as possible, and facilitating eating, maybe with softened diets, pain medications. The goal is comfort and dignity.
Right.
And this really raises that important question for us. How do these diverse therapies truly complement each other in complex cases? When there's no single magic bullet, how do you combine them for the best outcome?
Yeah, the multimodal approach. And just to tie a bow on the treatment piece, what about the practical reality for horses who undergo some of those more radical surgeries, like the partial mandibulectomy you mentioned? Does it significantly impact their ability to live a normal life afterwards?
It's a good question. And interestingly, horses that have undergone radical surgical excision, including partial mandibulectomy, they might initially have some difficulty prehending short grass, picking it up cleanly with their lips and teeth.
Makes sense if part of the jaw's gone.
Right.
No.
But their post-operative appearance is generally considered quite acceptable cosmetically. And they can often, remarkably often, return to their intended use, whether that's riding, breeding, or just being a happy pasture companion.
That's incredible adaptability.
It really is. It's a testament both to the horse's resilience and the success of these advanced surgical procedures when performed correctly.
So what does this all mean for the horse and owner in the end? the prognosis. That's where it really comes together, but it's clearly not a single, straightforward answer, is it?
No, definitely not. It's highly variable. The outcome for equine oral neoplasia depends on several critical factors. It creates a complex web of possibilities.
Okay, first, the tumor type itself plays a huge role, right? Benign versus malignant.
Absolutely fundamental. Benign tumors like those ossifying fibromas, odontomas, and many of the melanomas in gray horses generally have an excellent prognosis if they're completely removed surgically.
But the malignant ones,
Malignant tumors like SECs, fibrosarcomas, or those aggressive sarcoids, they carry a much more guarded to poor prognosis simply because of their aggressive nature and potential to invade or spread.
location, 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 that matters too.
Hugely. The location is another key factor. Tumors in easily accessible areas, think lips, the front part of the tongue, the incisor region, they tend to have a better prognosis. Why? Because complete surgical excision is more achievable compared to those in difficult locations like the pharynx, the larynx, the base of the tongue, or tumors that have already invaded the sinuses or deeper bony structures. Complete removal there is just much, much harder.
And naturally, size and invasiveness are critical. Stands to reason that smaller, non-invasive tumors have a significantly better prognosis than large, deeply invasive ones that have really taken root.
Exactly. Size matters, and how deep it goes matters.
And then there's metastasis. Has it spread?
And of course, the presence of metastasis, whether it's spread to regional lymph nodes or worse to distant organs like the lungs, that significantly worsens the prognosis.
Yeah.
Once it's spread systemically, the battle becomes much, much harder, often shifting focus entirely to palliative care.
This brings us right back to where we started this deep dive.
Yeah.
Early diagnosis. It really sounds like the single most critical factor influencing a favorable outcome.
Without a doubt.
It just underscores a profound importance of owners being vigilant. Noticing those subtle changes in eating habits, any facial swelling, any signs of oral discomfort, because catching it early changes everything.
It gives you so many more options and usually much better ones. And the response to treatment itself can vary too. Some tumors respond very well to the initial therapy chosen.
And others don't.
And others prove refractory, meaning they just don't respond well, or they have a high rate of recurrence even after apparently successful treatment. It can be frustrating.
Yeah.
If we connect this to the bigger picture, the intricate and complex anatomy of the equine head truly dictates the limits of treatment and the potential for a positive outcome. It's such a complex area, anatomically speaking.
It really is a puzzle, requiring multiple perspectives. Given all this complexity, it sounds like a team approach is often the best way to navigate these challenges.
Absolutely. Due to that complex anatomy and the often advanced nature of these tumors by the time they're diagnosed, a multidisciplinary approach is often best. That might involve a veterinarian experienced in equine dentistry, an equine surgeon, maybe even an oncologist if one is accessible.
Bringing all the expertise together.
Exactly. That collaboration is often recommended for optimal management and to provide the best possible outcome for the horse.
Well, we've certainly journeyed far today. From understanding the hidden nature of equine oral tumors deep inside the mouth to exploring the comprehensive diagnostic tools and the wide array of treatment strategies available, the core message here, I think, is undeniably clear. Vigilance and early action are absolutely paramount for the well-being of our equine companions.
Couldn't agree more.
So here's something to think about. Considering the incredible challenges of diagnosing and treating these conditions in animals that can't just tell us where it hurts, what new appreciation do you, our listener, have for the ingenuity and advancements in veterinary medicine? And maybe, how does this deep dive inspire you to be an even more observant caretaker or advocate for animal health in your own life?
Yeah, what stands out to you from all this?